Καλημέρα σας. Είναι μεγάλη μου τιμή που μοιράζομαι το βάθρο με τους συνεργάτες, συναδέρφους από το Υγεία and Beyond. Ευχαριστώ τον κύριο Βάρδα για την πρόσκληση και τη συμμετοχή στο Cardio Elite. Θα ήθελα όμως αντιστρόφως να εκφράσω εγώ το θαυμασμό, την τιμή που νιώθω που προεδρεύομαι από δύο γίγαντες της ελληνικής καρδιοχειρουργικής. Σας ευχαριστώ πάρα πολύ για τα εισαγωγικά σας λόγια και θα προσπαθήσω να είμαι αξιοπρεπής και συνεπής απέναντι σε αυτό που ανακοινώσατε. Βάση περιπτώσει, όταν κάνεις δύο πράγματα και πας μπροστά που λέμε, στηρίζεσαι σε ώμους γιγάντων. Λοιπόν, σας ευχαριστώ πολύ. Για λόγους ευγενίας, αγαπητοί συνάδελφοι, θα μου επιτρέψετε να εκφέρω το λόγο αυτό στην αγγλική, διότι έχουμε επισκέπτες που φέραμε από την άλλη άκρη του κόσμου, Professor Hermann Reichenspurner, Professor Jörg Grünefelder, Professor Gula Murtaza, and Piros Davievala. So out of courtesy, they've traveled across the world to be here with us. Allow me to give my presentation in English. Less is more, minimal invasive heart surgery and the new patient journey. And let me put things clear right up front. The new patient journey, perhaps I should call it the early new patient journey, because a minimal cut will not change the long-term result. And still, many people consider the median stenotomy the golden standard for many of the things that I'm going to show you today. In the end of the day, what really counts is the long-term impact on the patient's life. So, and we know very well, when it comes to major complications, but also major efficiency and durability of the result, the two methods are similar, equal. As Dr. Patakos's patient just announced on the microphone before, and I found it very, very amusing what he said. He's doing excellent after 17 years of a bypass operation. He was in a coronary session. There is no difference actually in the long run, and patients will only remember the early experience. So let me put it in the right framework. But for the early experience, the patient journey may indeed change with the new methodologies. These are my disclosures. Now, as you all know, I don't like too much surgery. Okay, so too much surgery is not always good. So we went from here to here. And technology changes, techniques are changing, but also, ladies and gentlemen, patients are changing. In the very essence of the primary Hippocratic principles, primum non nocere, if you can produce the same efficiency, the same durability of result, but with harming less the integrity of the body of the patient, harming his health less, even if in the initial stage, then you should do it. Patients are changing as well. And I keep saying that 30, 40 years ago, perhaps my two chairmen today will confirm that, or 40, 45 years ago, until you entered practice in this city, patients were happy to come out alive of a heart surgery theater. Now, 20 or 15 years ago, patients were happy to come out alive and have as little complications as possible. Nowadays, patients want to come out alive of the heart surgery operation theater. They want to have little complications, and they want to go back to their business as soon as possible. They want to mobilize as soon as possible. Believe it or not, the number one thing patients are asking me when they come see me in my practice, both in Singapore as well as here, is not, will I survive? No. Or how much is my risk? Number one question is, I have a business contract to sign in 3 weeks' time. Can I go? Am I going to be intact for Christmas? Am I going to be able to play golf with my friends in 4 weeks' time? These are the kind of questions I get. Now, there is a background to the progress of minimal invasive heart surgery, which you heard on this podium today by Dr. Koutouzis and others. Background is that, of course, in the same principles, a patient who can get his treatment with a catheter will go for the catheter. I would do the same. My family would do the same. That's the ultimate question. What would I do for my brother or myself? So it's absolutely clear. So we surgeons have a last bastion, a last fortress, basically, which is less invasive techniques, well suited between catheter and median stenotomy for our profession to extend and survive, but beyond that, to offer good solutions in the patient journey. Before, it was medicine and median stenotomy, but now we have a huge variety of solutions which we can customize in discussion with the cardiologist and adapt it to the specific patient, because if we don't, this is how we're going to end up in front of the stairs of a hospital, meaning without a job. So, on a lighthearted note, the cardiologist is much closer as we think in every single aspect of our profession. Now, allow me to bust a few myths. Obviously, my talk is more directed to non-cardiologists and heart surgeons, but let me bust a few myths. There is a myth that minimal invasive is new, is experimental. And it's a bad experience I had in Singapore because a lot of competitive doctors who couldn't do minimal invasive, and it's not a big deal. It's not a big deal. It's teachable. They used to tell the patient, oh, don't try this. This is very new. It's still experimental, which we all know it's not. Minimal invasive heart surgery is there since 1996, perhaps earlier. But this is where the first publications start appearing on the internet, in the world literature about invasive. So minimal invasive is not experimental. There are huge series. There are thousands of publications out there which compare the benefits or advantages and disadvantages over very many years. MICS is therefore not controversial. If you define the patient selection, select the patients well, then minimal invasive can be a very powerful tool in your quiver, in our armamentarium, in dealing with the patient's disease. In Singapore also, and we used to have very wealthy patients there, the competitive doctors told them, oh, if you want to have the minimal invasive, the same doctors who used to sit in my workshop a week before, because they weren't able to do minimal invasive, they used to send the patient to Cleveland to get their minimal invasive done. So I got curious. I went to Cleveland to see what they're doing. And they have a superb program, no worries. But within 1 week, I saw a mini J stenotomy. That was all. And in our little program in Singapore, we were doing 2 minimal invasive procedures a day. So meaning to say this is also a myth. You don't necessarily need to go to Professor Reichensburger in Hamburg to get your minimal invasive done. Right, Herman? You can, it's teachable, and many people now know how to do minimal invasive cardiac surgery. So, if we want to reach somewhere we haven't been before, as our heart surgery collective, we must do things we haven't done before. Let me explain to you the law of diffusion of innovation. I don't know if my pointer works. Okay. Law of diffusion of innovation. With our new center and without joint collaboration, we want to move our position, the tipping point, more to the left. Down here, take the example of Apple, for example, with the new iPhone. The innovators is Apple themselves, or the clinics, the departments in the world who are producing new technologies and techniques in minimal invasive heart surgery. Then there are the early adopters. In my humble experience, usually places like Germany, France, some places in the UK who are the first to adopt the new techniques and spread them around the world. They're very progressive heart surgeons. Early majority, some of our Greek colleagues belong to the early majority. That's where we are. Then there is late majority, people who need to be convinced over 10 years before they start minimal invasive heart surgery. And then there is the laggards. That refers to my mother, who, if Mr. Mitsotakis does not, eliminate fixed telephone lines, she will not buy an iPhone. So these are the late adopters of technology, okay? Hence, in Greece, we must move more to the left and become one of those countries which are not only early adopters, but who produce technical knowledge and new techniques. And that is what catapulted us to the level Dr. Prapas has mentioned before as a program in Singapore. Now, who is the cardiologist, who is the heart surgeon here? Any guesses? Well, of course, we know who is the cardiologist, and rightfully so, because they are doing amazing things. The lion is the cardiologist, and this is the heart team today. But things move on, things progress. This was Singapore 120 years ago, and this is Singapore today. So as I said, we moved from here to here. And this is now how the incision or the access can change the patient's life. For those who don't have a specific clue what exactly minimal invasive or endoscopic is, we went from the median stenotomy to a small incision in the fourth or fifth intercostal space on the left for a bypass procedure, a small incision in the second or third intercostal space on the right for an aortic valve procedure, and the usual fourth intercostal space in the right side of the patient for mitral valve, tricuspid valve, atrial ablation, concomitant procedures of those, and sometimes also double valve aortic and mitral valve. All these procedures, ladies and gentlemen, can now be performed safely with the minimal invasive access. Now, I don't want to get into hyperspace theory, but minimal invasive is not equal minimal invasive. There are different universes there. There is direct vision minimal invasive, manual, so to speak. There is endoscopic minimal invasive, robotic minimal invasive, and the most minimal invasive is a catheter procedure, let's face it. We were inaugurating the Indian Society of Minimal Invasive Heart Surgery maybe 7-8 years ago. And I was, of course, proponent of minimal invasive on the podium and giving the keynote speech. And then Gino Gerosa, the Italian surgeon who developed the neocords, stands up and says, Theo, if you are minimal invasive, then I am micro-invasive. The whole audience laughs. A cardiologist raises his hands and goes, if you guys are micro-invasive, I'm nano-invasive. Again, the whole audience laughs. So this is the truth. The benefits, the proven benefits of minimal invasive cardiac surgery: decrease rate of infection. We see very few infections in patients with minimal invasive trauma. Less blood loss, patients tend to come out with an HB beyond 10, 11. Of course, patients lose less blood with less trauma. Less arrhythmias, less lactate and higher albumin. We, back in Singapore, had found a direct correlation between less lactate and less arrhythmias post-operatively, which means less burden and toxicity to the body throughout the surgical process. Decreased length of hospital stay, and that is the most important one. 2 to 5 days as opposed to 7 to 10 days, and of course, depending on your program. If your general ward beds are blocked, what's the point of doing minimal invasive and counting the day? And if your patient is ready to go home, but nobody to take him back home, there is no rehabilitation system or hospital, then he extends his stay in the hospital and basically skews your results. But in general, we know that patients with a minimal invasive procedure, they are faring better. They go home faster, and that's where the big difference comes. Mobilization is life, and the patient mobilizes much faster, both in the hospital as well as back home. When he goes back home, life continues relatively normally. He can drive, he can sleep on the side, he can carry weights, his wife's shoppings, whatever. So he can do these things, he can swim. And it's a great platform for synergy and growth as cardiology procedures are also progressing. The most important thing, if you ask me, is the customization and personalization of the procedure. Take, for example, the hybrid agenda. As I said before, either medicine or median stenotomy. That was the case many, many years ago. Now, advances in cardiology, as well as in heart surgery, provide us with a variety of solutions which you can customize for the particular patient. Patient with a mitral valve regurgitation and a single blockage, single stenosis. Usually, cardiologists can stent the stenosis and then send the patient 1 or 2 months later for an endoscopic mitral valve repair. TAVI, however, a single blockage in the LAD. Patient goes to the surgeon, he can do the beating heart, minimal invasive solution, Lima on LAD, and then back to the cardiologist for a TAVI. And all these hybrid 1-stage or 2-stage solutions will progress in future. I see great future in there. Hybrid coronary vascularization, for example, can change the patient journey. It's the best of both worlds together. Who tells us that a vein bypass is better than a stent in the right coronary artery? With an occlusion rate for the stent of around 3% at 1 year, but of a vein bypass of 12 to 18%. So perhaps a hybrid solution in the future with arterial grafts on the culprit lesion and stents in the non-culprit lesion may benefit the patient a lot in the short and long run, and also give him the benefit of a very small cut and immediate mobilization. This is an old slide from 2015. Nowadays, in our practice, mitral valve, almost 100% minimal invasive, combined mitral valve and tricuspid valve, also almost 100%, atrial ablation, mitral valve, 90%, bypass surgery a bit less, simply because targets are very bad, ejection fraction may be less than 30%, a very, very severe left main stem stenosis is a deterrent for the surgeon to put the heart in awkward positions, and some surgeons prefer to do it open, have a better control of the situation. Also, severe COPD, where you cannot deflate one lung, patient will not keep saturation, irradiation, and different rare conditions that prohibit a severe calcification of the aorta and the femoral vessels may prohibit a surgeon of progressing with bypass, minimal invasive bypass. There are other extreme conditions which I encountered in Singapore when I was in Asia many times because patients are very, very small. So I asked the surgeons who are a bit against minimal invasive, why? Too old, too scared, too much competition, is too difficult, inertia, comfort zone, whatever it is. As a proctor in minimal invasive for many years, and I'm sure the other proctors here from overseas will agree, that it's easy to learn. If you have a structured syllabus, you can do certain simple things. Don't start with the Barlow's on the mitral valve with endoscopic procedures, for example, but they can be learned. So we're looking at a program which we want to transplant here in Athens, one-to-one, a full program that covers all diseases in a minimal invasive fashion in a comprehensive way. Let's look at some outcomes: shorter hospital stay, less infection rates for minimal invasive, better lung function. It's important because the thorax doesn't destabilize as it does with median stenotomy, so patients tend to have a bit less pain and better lung function, so they recover faster. These are personal outcomes, so not too bad. Minimal invasive fares very, very well compared to open for all kinds and all strata of patients. These are some of the patients following mitral valve procedures. Of course, it's a game changer for the patient in the early postoperative phase. And this can be also obese patients, as you can see on my left side here, patient 150 kilograms after endoscopic aortic valve replacement, or a lady with big breasts. This lady is even happier because you can't see anything. You just enter one intercostal space lower and travel up before you enter the chest. Now, all these patients have benefited in their early stage, in their early journey. You see this patient on the left side. I gave him a full surgical revascularization. I don't remember 3 or 4 grafts, and he was running marathon a few weeks later. Badminton player, a very senior police officer in Singapore, and then you see the first hybrid case we did together with the cardiologist, same stop hybrid, in the same hybrid theater. You see him, he's in the ICU. After this photograph, he went home. Some innovations we introduced: the core knot automated knotting device in Asia. Some 12 years ago, I introduced the uniport heart surgery without any additional incisions, just one workport incision, which of course looks even better. Cosmetics is the last thing we're thinking about in minimal invasive. Of course, it's superior to median stenotomy. Combined procedures, mitral valve and bypass on the right. The transmammillary procedure, as you will appreciate here, that's all the patient gets to remember on the far right side of the picture. The robotic surgery in Singapore. And then we have the endoscopic, totally endoscopic aortic valve surgery, which is also a game changer for the patient. They really come asking for it. They're educated. I'm not going to show the whole video in the interest of time. The camera gets you right on the spot, over the aortic root, where you can conduct a very safe aortic valve replacement procedure. And it follows certain selection criteria. For example, the aorta must be 50% to the right of the sternum. It should not be to the left. We have, a few years ago, they did a live transmission to Greece, the first holographically supported surgery in the world. Again, for now, these things are gadgets, ladies and gentlemen, but what is a gadget today may be routine tomorrow. Basically, we take the patient CT scan, we transform it into a hologram wearing special glasses and Microsoft HoloLens software, and this can guide me where I place my incision exactly, where I place my clamp, my vent, and so forth. Gives me a bit more ergonomy and strategy for my procedure. In this particular case, I was going to go into the second intercostal space, but the hologram, which fits the patient one-to-one, clavicle to xiphoid, gave me another clue, a bit lower, and that helped me a lot facilitate the procedure. Once I'm happy and I know how to proceed, I just pinch it and toss it away. So, in conclusion, we have to become a bit of cardiologists, ladies and gentlemen, adopt minimal invasive, become a bit of a lion and a zebra, a libra, perhaps, and introduce new meaningful protocols that will add on the minimal invasive cut or procedure in the operation theater, such as the fast track or ERAS protocol, enhanced recovery after surgery, which we started adopting now at a year hospital, meaning a special preparation of the patient before the surgery, special narcosis during the surgery. Here our chief anesthetist has extubated our last minimal invasive bypass patient, full revascularization in the operation theater. The patient was ready to go to the general ward in 6 hours, and in 3 days he left the hospital. So that's the fast track and ERAS program, which takes into account certain parameters of prehabilitation and post-habilitation. We need to introduce good quality control, for example, BPEs and scorecards, best practice elements. That means certain conditions and quality criteria must be fulfilled so that the patient can score green on our scorecard. If the patient has a re-exploration for bleeding or any infection, then of course becomes red on the scorecard, so that we know where we are, we can self-reflect for our program and move on. So the way forward, I think median stenotomy will soon not be the golden standard, whatever that means. Minimal invasive bears significant advantages for the patient, at least in the early phase and his rehabilitation. Cardiologists and heart surgeons can now offer personalized and customized heart treatments with a much richer quiver of solutions. The hybrid portfolio, I'm convinced, will grow. I think Greece deserves to be at the forefront of developments and not stagnate or move very slowly as competition is rising in the region. And MICS, minimal invasive cardiac surgery, will offer a clear, meaningful, and attractive differentiation in the short term. So we must integrate innovation and quality control as a matter of self-reflection and improvement. And with that, I came to the end of my little presentation today, and will thank you very, very much for your attention.
Ευχαριστούμε πολύ τον κύριο Κοφίδη για τα τόσα ωραία, προοδευτικά, φιουτουριστικά στοιχεία τα οποία είδαμε και ακούσαμε. Υπάρχουν, δεν ξέρω αν θα έχουμε ερωτήσεις και απαντήσεις, αλλά αν υπάρχουν ένα-δύο συνάδελφοι που θέλουν να ρωτήσουν κάτι, θα είναι χαρά μας. Παρακαλώ. Ναι.
Θα πάρω πάλι το λόγο, συγγνώμη για τις παρεμβάσεις. Απλώς αισθάνομαι την απόλυτη ανάγκη να πω δύο-τρεις κουβέντες βασικά όσον αφορά τον κύριο Κοφίδη. Καταρχάς, θέλω να επικαλεστώ τη θεωρία, μάλλον την ανάλυση που έκανε κάποτε η κυρία Μαρία Ευθυμίου, δεν ξέρετε, την ιστορικό, η οποία στην ερώτηση τι είναι οι Έλληνες, γιατί είναι οι Έλληνες, γιατί είμαστε έτσι οι Έλληνες, είπε ότι έχουμε τρία σημεία. Ο Έλληνας είναι γενναιόδωρος, είναι ενθουσιώδης, είναι γενναιόδωρος και είναι και ρυψοκίνδυνος. Και ο λόγος, αγαπητέ Θεόδωρε, που είναι ρυψοκίνδυνος, είναι διότι είμαστε ένας λαός της θάλασσας. Ταξιδεύουμε στη θάλασσα και η θάλασσα είναι πάντοτε ρυψοκίνδυνη, γι' αυτό τελικά και ο Έλληνας, η Ελλάδα ποτέ δεν πεθαίνει. Όμως, παρόλα αυτά, πρέπει να πω κάτι που είπε ο Σταύρος ο Ξαρχάκος, ότι δικαίωμα στην έπαρση έχει μόνο η ελληνική σημαία. Και αυτή την ελληνική σημαία φέρνει σήμερα ο Kofidis στην Ελλάδα. Το Θεόδωρο Kofidis τον γνωρίζω όταν ήταν ακόμα μικρός. Ήταν στο Ανόβρο τότε, έκανε την ειδικότητά του και ένα βράδυ που ήμασταν σε ένα κλεισάκι εκεί πέρα του Αμβούργου. Εγώ μόλις είχα αναλάβει τη διεύθυνση της κλινικής στο Πανεπιστήμιο του Αμβούργου και μου λέει: θέλω να γίνω μεγάλος γιατρανός, θέλω να γίνω καθηγητής, μπλα 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 κλπ. Του λέω: Θεόδωρα, έρχομαι από το Στένφορντ. Εκεί ήμουν στο Subway να δώσει μεταμοσχεύσεις. Πρέπει να πας στο Στένφορντ να κάνεις έρευνα. Το έκανε. Πήγε 2 χρόνια, έκανε την έρευνα και συνεχεία έφυγε και συνεχεία ακολούθησε την πορεία προς Σιγκαπούρη. Έστειλα 1-2 μαθητές μου πριν από μερικούς μήνες στη Σιγκαπούρη και αυτό το οποίο μου μεταφέρει είναι το εξής. Ότι αυτό που έκανε ο Kofidis στη Σιγκαπούρη δεν υπάρχει στον κόσμο. Δηλαδή δεν είναι μόνο χειρουργός ο Θοδωρής. Κάνει έρευνα, έχει πάει στη δική του βαλβίδα και έχει φτιάξει ένα τεράστιο έργο στη Σιγκαπούρη το οποίο εύχομαι να το μεταφέρει και στην Ελλάδα. Και ήταν μεγάλη πράξη αυτή που έκανε η διοίκηση του Υγεία να φέρει εδώ πέρα τον Θόδωρο, ο οποίος θα οργανώσει και το πανεπιστήμιο το οποίο θα έρθει τις επόμενο χρόνο και στην Ελλάδα. Τώρα, όσον αφορά τη νέα αυτοτεχνική στις μητροειδούς, επειδή είχαμε ξεκινήσει στο Αμβούργο να κάνουμε τις μικροεπεμβάσεις τότε το 1997-98, είχαμε κάνει και το πρώτο bypass με ρομπότικ. Ένα bypass και μετά από 6 ώρες αυτό το bypass έκλεισε. Μετά την βάλαμε στην άκρη. Μετά ήρθε ο προφέσορ Ράχινος που είναι εδώ πέρα και τα συζητήσαμε πριν.
Αν έχετε την καλοσύνη, κάποια ερώτηση.
Ξεκίνησε, όμως παρόλα τα 25 χρόνια που έχουν περάσει Θόδωρα από τότε, το ρομπότικ δεν έχει καθιερωθεί στην καρδιοχειρουργική. Είναι πάρα πολύ δύσκολο. Ωστόσο, εκείνο το οποίο καθιερώθηκε και φυσικά και κάνει όντως αυτή τη μεγάλη πρόοδο, και το οποίο μας διατηρεί και εμάς τους καρδιοχειρουργούς να έχουμε τη δουλειά μας στην ουσία, είναι αυτό το οποίο παρουσίασε σήμερα και το οποίο θα παρουσιάσουν και τα άλλα παιδιά. Είχαμε τότε ξεκινήσει με την αορτική βαλβίδα, με μικρή τομή. Κάναμε και...
Είπαμε αν έχετε κάποια ερώτηση.
Τελειώνει. Η ερώτηση είναι η εξής. Εστιάζοντας κυρίως στη μετροειδή βαλβίδα, την οποία είναι δική του εφεύρεση. Το θετικό είναι ότι παίρνεις τα 2 leaflets και συνέχεια αυτά τα σταθεροποιείς δεξιά και αριστερά στο μητροειδή ή πάνω στην κομισούα.
Λοιπόν, πολύ σύντομα για να αδειάσω το βάθρο για τους ομιλητές που θα μιλήσουν για τη ρομποτική καρδιοχειρουργική. Λοιπόν, αναφέρεται ο συνάδελφος, ευχαριστώ για τα καλά σου λόγια, Νίκο, στις 12 καινούργιες τεχνικές που εφήβραμε για την επιδιόρθωση της μητροειδούς, οι οποίες απλοποιούν, στανταρντάρουν, ας πούμε, τον τρόπο επιδιόρθωσης μητροειδούς. Είναι 12 διαφορετικές τεχνικές. Θα χαρώ πολύ εν ευθέτω χρόνο να μιλήσουμε έξω, γιατί μπαίνουμε σε διαφορετικό τελείως κεφάλαιο τώρα της επιδιόρθωσης μητροειδούς. Για την ρωμαϊκή αψίδα, μία από τις τεχνικές, για το μηνόταυρο, μία άλλη από τις τεχνικές και πώς διεξάγονται. Και μπορώ να σου διαθέσω και τις animations που έχουμε ετοιμάσει. Ίσως είναι επεξεργαστικές.
Ευχαριστούμε πάρα πολύ. Ευχαριστούμε πάρα πολύ τον καθηγητή κύριο Kofidis και θα προχωρήσουμε στο επόμενο session, το οποίο αρχίζει αμέσως τώρα. Ευχαριστούμε πολύ.